Sandy Magaña, PhD, MSW, holds the professorship in autism and neurodevelopmental disabilities in the Steve Hicks School of Social Work. She received a Master of Social Work from California State University, San Bernardino, and her PhD from the Heller Graduate School of Social Policy at Brandeis University. Magaña completed postdoctoral training from the NICHD-funded postdoctoral program in developmental disabilities research at the Weizmann Center, University of Wisconsin-Madison. She was a faculty member in the UW-Madison School of Social Work for 12 years and later served as a professor at the Department of Disability and Human Development at the University of Illinois at Chicago. Her current research includes investigating racial and ethnic disparities among children with autism and developmental disabilities and developing culturally relevant interventions to address these disparities. She has received funding for her research from the National Institute of Mental Health, National Institute on Aging, National Institute of Child Health and Human Development, and National Institute on Disability, Independent Living, and Rehabilitation Research. Please welcome Dr. Magaña. I'm going to stop sharing my screen so that you can share your PowerPoint, Dr. Magaña, and let me know if you're having any trouble with that. Excellent. Her topic today will be culturally tailored interventions. What should we consider? You might be muted, Dr. Magaña. We can't hear you.
There, I had to stop sharing in order to get my mute button. So let's try it again. Let's try this.
Yes, we can definitely hear you now. Thank you.
Okay, great. Here we go. So this is really great for the second day. I mean, this conference is, you guys have done such an amazing job organizing the conference, and it looks like we have such great attendance remotely through different means, through Zoom, through Facebook, through a lot of different means. So this is really impressive. I'm learning a lot about how do you organize a remote conference from you guys. And so, yeah, I'm going to talk about culturally tailored interventions, what we should consider, and just to give an overview, I want to just ask the question, why we should culturally tailor interventions, what are culturally tailored interventions, what do we mean by that, and then sort of processes that might be used and best practices. I'll give some examples from my work, and I want to hear your ideas about in the discussion about what you might culturally tailor. So so just before we begin, I do want you to think about as we're going through the presentation, how you might use the ideas or concepts we talked about in your profession or practice or research, and or how are you using it? Because you might already be doing some of these things, and additional ideas or examples that you've tried, because I think it will be nice for all of us to think about how we can use this information practically. So starting with why we should culturally tailor interventions. You know, I will say that the majority of evidence-based interventions are not tested with culturally diverse populations. When I do literature searches, I find great interventions out there, but I look at the population that they tested the intervention with, and sometimes they don't report demographics. A lot of times they don't report demographics, and rarely are there different racial ethnic minorities in population. They're usually mostly white. So diverse groups do have unique needs and often fall through the cracks of services and healthcare systems. And we talked a lot about that yesterday. For those of you who were on, you learned about many different ways that there are barriers to receiving needed services And so interventions tailored for specific populations, their needs and outcomes, can address their needs and reduce some of the barriers, some of the disparities. And we talked about with disparities how you really need to address disparities at different levels. So individual, family, you know, community, and even macro policy levels, right? Having all of those going on simultaneously is ideal. So, but I'm focusing more on the individual family level with culturally tailored interventions. And I showed this yesterday, but I think it's really important in light of what we're talking about, because if you think about, so we talked about equality versus equity, and how equality is giving everybody the same thing, right? In this case, everybody has the same size soapbox, but it doesn't meet everyone's needs. And so how do you, to have equity, you really need to make sure you have the right supports in place for the group or population. And so that's true for people with disabilities, but it's also true for different populations, that if you tailor the intervention to meet their needs, they're more likely to access and use that intervention. So just to talk about what we mean by culturally tailored intervention. So we want to make sure the intervention is culturally responsive to the group that you plan to serve. And so that could be creating a new intervention that's culturally tailored to a specific group, or adapting an existing evidence-based intervention to a specific group. So I'll talk a little bit about both of those. This is just models different ways to think about cultural adaptation. There's surface level adaptation and deeper structure approach. Now, I will say the surface level adaptation is super, super important. If you just do that, that's amazing. You're going to accomplish a lot. So having bilingual staff in the language that, you know, of the people that you're working with, identifying their social cultural needs, using culturally specific interpersonal styles, you know, including pictures and so on that reflect the population, that will go a long way if you do that. Deeper structure includes, you know, embedding values and practices and traditions from that group. So you're going a little deeper than you would with the surface level. And then looking at how the social, cultural environments and historical factors influence health and the related behaviors and practices. So I don't say that, you know, and there has been some research kind of comparing. I've seen a study where they compared interventions that use surface level or deeper structure approach. And to be honest, they didn't find that one was better than the other. A deeper structure includes the surface level adaptations. And so, so that, I guess the question's up in the air whether deeper structure is better or not. So, and just in terms of looking at evidence-based practice or interventions in diverse communities, we're talking about cultural adaptation, what that is. So it's basically reviewing and changing the structure of a program or practice to more appropriately fit the needs and preferences of a particular cultural group or community. So that's a nice way of saying it, I think. This slide shows that if you're going to take an evidence-based intervention and try to culturally adapt it, sort of what the process is, because it's a very process-oriented activity. And so if you look at, so first you might identify possible evidence-based practices that you want to use, you know, depending on what it is you're trying to address, right? So you do a literature search on evidence-based practices, you decide on one, and then you want to evaluate the cultural appropriateness of that practice. So has that practice been tested with different populations? Are they taking into account certain needs? And it's important to break down the evidence-based practice into its components and determine which component you want to modify. And then you evaluate, you know, so you try out and evaluate, well, I'm going the wrong direction, it goes this way. Analyze the cultural factors that affect the programs, right? And so you might do this through, you might do focus groups with stakeholders, you know, in this part of the process to really look at you know, how do you break down these components? We've done this with the intervention I talked about yesterday, parents taking action. You know, generally, like for example, we were culturally adapting it for the Chinese American community. I have a grad student who's doing that. And so she's been doing focus groups with stakeholders to, you know, so both providers that are Chinese in the Chicago area, as well as family members, and to really find out what's important, what are things that need to be modified, and sort of analyzing those factors. And then you make the changes, make the modifications, document that, and then try it out. You know, do a pilot test to see if it's feasible, if it's acceptable to the community, you know, making sure it's going to work. And that can be an iterative process, because you may try something out and find out that, no, you need to modify it further or take into account other things. You know, and the evaluation process is also part of the iterative process. You may evaluate, go back, modify again, evaluate again. So it's not all in one direction. I mean, it's kind of linear, but this process is, a lot of these processes are going to be going back and forth. So here's some things just to consider as you are adapting, or if you're considering that you have an intervention you want to adapt. You have to consider the cost, right? So a lot of times evidence-based practices get copyrighted, they get sold, you know, through book, you know, publishers or things like that. And so really sometimes the person who creates the program doesn't have any control over it after that. So that's a one thing to consider, is you want to give up your control, because then you're going to give up the access to the intervention. One of the things I've heard organizations talk about as they're trying to implement evidence-based interventions, they're typically very expensive, so they have to buy all the materials, and they have to pay for the trainers. And this is, you know, of course you would have to do that. But then they train their staff, and then their staff, you know, may not be with them forever. They may leave within a year, and they've spent all that money, and now no one knows how to do the intervention. So there's a lot of cost involved for organizations, I think, in addition to families. So you want to make sure that your the materials are engaging, and that you minimize the text and have more visuals for families, and look at things like literacy levels if you're dealing with low income or low resource families, making sure that you're taking that into account, and that the themes that you're working with are culturally relevant. You have images and content that are specific to that group. Other things that are kind of important, very important actually, is that you involve stakeholders. So we talked about doing focus groups as one way of doing a cultural either adaptation or creating a project. And so involving the stakeholders, the families themselves that would benefit from the intervention, if the intervention is targeted towards autistic adults, autistic youth, including them as stakeholders as well. And you could include community practitioners, people who are working with the population, community advocates. So thinking about who are the stakeholders and how can you involve them in the whole process. That really increases the adoption of your intervention in different communities, if you're including people who may give you ideas of how an organization might adopt the project. So other things to consider, there's a lot of research showing that having a navigator or a peer mentor, there's a lot of research emerging about peer mentors. I think I see that more in the mental health field than I do in this field, but I see it emerging in this field as well. Having somebody who's a peer who's also helping with deliver the intervention can be very powerful. You know, it helps to show that the community, you know, that member's part of the community and you know, creates acceptance and so on. So it's really an important thing, I think. And then of course you have to think about accessibility and reducing the effort for whatever population that you're working with. So making sure if it's a low income population that that the intervention is in a place that's accessible. So either close to public transportation, close to where families live, or even in the family homes. If you're doing a group program, you know, making sure that you're providing childcare, snacks, and other things to make it easier for the families to bring their kids, and then having small groups of families so that they can connect. And you know, I say consider home visits because you know, I talked yesterday about parents taking action. I'll talk a little bit about how we created that program, but we decided to do home visits because you overcome several barriers: childcare, transportation, also the convenience of being able to reschedule if the person can't come, making sure they get all the content. But I know home visits can be challenging if an organization wants to adopt the intervention, because that's an additional thing that they have to implement or monitor. So just to reiterate some of the things we talked about in terms of best practices for culturally tailoring interventions, involving stakeholders, using peer-based methods, if you can, creating and adapting, translating materials for the specific group, ensuring the content is relevant and salient to the group, ensure accessibility and reducing effort and barriers. And I mentioned consider using ecological validity framework. It's just, or other kinds of frameworks, and I'm going to talk a little bit more about that one because we did use it to help us think about cultural issues. So I talked yesterday about the research behind parents taking action, but today I want to talk about the process we used to develop this intervention. So this was, this was an intervention that we actually created, but we also used evidence, you know, in terms of the content and materials that we delivered. So we did use existing evidence. So the first thing we did was form an advisory committee. As I mentioned, that involving stakeholders is important, and so that's the way we did that. We used the ecological validity framework, and we used promotoras de salud, which I'll talk a little more about and mentioned yesterday. So our advisory committee consisted of community partners, our community partner, because we partnered with a community organization for our pilot study when we were developing this. This was in Milwaukee, Wisconsin. The organization was a PTI, parent training, I forget what the I stands for, a parent training organization. We also included people from a local clinic that were working with Spanish-speaking families of kids with autism. So we had a pediatrician and a social worker that were bilingual and worked with that population, our investigator and research staff, and definitely very important, Latino parents were part of that advisory committee. We had an autism expert who had been working with Spanish-speaking families. And so we met several times over the course of a year just to develop the content of the organization. So, you know, we first asked this group, what should we include? What should the content be? The idea was we were going to provide an educational intervention. So we weren't going to do coaching or intervene directly with the children, but we wanted to provide information to Latino parents because we know that they often don't get that information even after the child's diagnosed. And so, you know, we would go back to them after we wrote some of the content, get some feedback, and sort of an iterative process there too. This is our original advisory committee in Milwaukee. And the young girl sitting on the chair is autistic herself. She must be in her 20s now. I bet she's doing really well. I stay in touch with her mother a lot. Her mother was working with this organization, and they ran a support group of Spanish-speaking families in Milwaukee that was very robust and strong. And so, so they really helped a lot with thinking through this intervention. I mentioned the ecological validity framework. So this is something that you could use to sort of think about different dimensions that you might consider when you're trying to develop or adapt an intervention. So it's important to consider language, you know, what is the language of the population you're serving, right? Making sure you're addressing that. Persons, who's gonna deliver the intervention. In this case, we chose promotoras or community health workers. They were from the same cultural and geographic community. Metaphors, we included in our manual sayings that were common in Spanish. We also incorporated storytelling. We actually learned this from the promotoras that they really like to start each session with a story. And so we incorporated that into the manual. And we tried to incorporate cultural values of the community, familism, personalismo, and then goals, you know, that should be part of any intervention, but thinking specifically about what the goals might be for this population. Methods, thinking about making sure your methods are flexible enough that families can do it, and that relationship building is important as part of that, including the whole family. So being able to have material that, you know, the whole family can benefit from. And then, you know, the context was we were working with immigrant families, Spanish-speaking immigrant families who are primarily low income. And so taking into account the home visit model helped take into account some of the barriers that this population had. So this is the curriculum we came up with. We originally did it in 2 modules, but not necessarily in the order that's presented here, but a lot of psychoeducation or just information about autism, child development. What does the evidence show about what is effective for children with autism? So really providing that background. I noticed when we searched the internet for Spanish-speaking materials, there are more materials now than they were at this time, but there was never anything, and I don't even know if there's much in English for parents that show what does the evidence say about interventions, because you can search the internet and find so many things on there. Some of it's good, some of it's bad, some of it has evidence, some of it doesn't. And so that's super important for all parents, I think, to understand what the evidence shows. We had some advocacy and parent support elements which were super important for this population, especially when we're talking about reducing disparities, right? Being able to help parents get their children to access the services that they should be getting. So we have some content there. And then also we want to address the stress of the parents, because we know that they're going through a lot. And so how do they reduce stress? How do they recognize signs of depression? We know that there are high rates of depression among parents. How do they recognize and get help for that? And then talking about autism to others, super important, because you know, I think this is not just specific to Latino families, but you often have family members who understand what you're going through, but you have family members who are kind of critical of you, or don't, you know, or they may say, well, you're just, you know, bad parenting. And so how do you talk to your family members, but also how do you talk to that person in the park that makes a weird comment? So the different range of people that you might talk to and what you might say. And then we go through evidence-based strategies, and Wendy Mihalacek was on our team, and Wendy is a professor at the University of Oregon, but she was at Wisconsin at the time that we were developing this. So she collaborated with us on this. She's a BCBA-D and has done a lot of research on applied behavioral analysis. So she pulled together and helped us write the strategy part of it to make sure we're including evidence-based strategies. We do a lot of explanation about play in this for families. Many families their children are getting therapy, you know, whether it's speech and language, OT, or ABA therapy. And, you know, if the person doesn't speak English, doesn't speak Spanish, the therapist, basically the parents are observing that this person's just basically playing with their child. So they don't really see what the benefit of that is, or what they're actually doing with their child. So we give them some insight into that for sure. And then we do talk about challenging behaviors as well. We have 2 sessions on that. And so the promotora model, the idea, you know, public health uses this model a lot. They use it to, it's basically the idea is you have somebody, and it could be in English, you would say health educator, right? Or community health worker. So the community health worker or promotora would be somebody from that community who's a layperson, not necessarily a professional, but they get training in the specific area that they're educating people on. So whether it's diabetes or heart conditions or other kinds of problems that are prevalent in a particular community. So they would provide that education to people. Maybe it's self-management for healthcare, diabetes. And so, you know, we thought this would be great to use in the autism world. And so, you know, providing this education from a peer, the whole idea of a peer. And so we made sure that our promotoras were mothers of children with autism. And they tended to be mothers of older children, you know, because otherwise they're going through a lot of challenges themselves. I mean, they are in general, but at least they've gotten through a lot of the hurdles that they had to get through in getting their child services, understanding the school systems. They have a lot of knowledge already based on their own experience with their child. And so all these different elements are an important part of being a promotora. And so these are our promotoras in Chicago. These moms were worked with me for about 4 years while I was in Chicago and implementing this intervention and other interventions that kind of developed from that. So they helped with a health intervention for parents, as well as an OT project where they were paired with OTs. So there are a lot of things that they continued to work on. And they came from, in Chicago, there was this amazing support group, Spanish-speaking support group called Grupo Salto. And Grupo Salto probably has over 500 Spanish-speaking families on their list right now. They have a very robust support group meeting once a month and do a lot of different things. So all these moms were already leaders in that support group. They wanted leadership opportunities. So it was actually really good. And that's one of the things we did to select promotoras was we made sure with the organizations, we asked the organizations to help us identify people who have some experience supporting other parents and are emerging in a leadership way with the different organizations that we worked with. So that proved to be a pretty effective way to find parent leaders or promotoras. These are the promotoras in California. So we did a 2-site study. We did the study in Chicago and Los Angeles. Not the entire Los Angeles area, because that's huge. We had to narrow it down. I think it was just West Los Angeles, but these are the moms and the promotoras in that area. And so really important if you're going to work with peer leaders that you provide adequate training and supervision for them. And so we had pretty extensive training before they got started on seeing individual families around the psychoeducation that they were going to provide. And during those training sessions, it worked out differently in different sites. So in California, they wanted to do it all in a week. So we had 4 8-hour days, and we paid them for their time, provided meals, made it very interactive and fun for them. So that's what the training looked like. In Chicago, their schedules didn't quite match up that way. So we did 8 sessions in 4 hours over the course of a month to provide that training. So it could be done in different ways. We put together manuals. We wanted to make sure we had a manual specifically for the promotora in English and Spanish. In that manual, there's instructions on what to say and what to do. And then we had a manual for the participants, which had all the content the same content and materials, but didn't have the specific instructions in there. We had a lot of visuals, so we created, so back in that time, this was not that long ago when we developed this intervention, but we used DVDs. That's so old school, right? So we created DVDs, and then we gave the promotoras a portable DVD player. And then whenever they, in the manual, it would prompt them to show the video or the video that they wanted to show. You know, some of them included novellas, or some of them were examples of strategies, and so that they could pull out the DVD player and do that. And I will say that it sounds so old school, but actually, because many of these families don't have internet in their home, even now, that worked. You know, it was an old school strategy, but it worked. Now, what we try to do is we have tablets, and so we make sure we have all the content uploaded on the tablet. We don't want to make it so that it requires internet, because still the families don't necessarily have internet in their home. So so we're using tablets instead of DVDs now. But this is just an example of our manual in terms of we're actually professionalizing it a little bit more. But what was really nice about this is you have all the different sessions had what are the key terms, what are the a check-in activity, so making sure that there's a check-in and sort of a question for them to think about, talking about the last session. And you can see the promotora manual, it says say, so tells them what they should start with or what they should say. We had objectives for each session, and you know, saying or dicho. So this one was little by little, one goes far, and then we just have a general discussion, but it's kind of an icebreaker, you know, before we get started into the content. And so, you know, I presented the results of this project yesterday. We did do a randomized trial, and, you know, felt the parents were feeling more empowered using the strategies and so on. I'm wondering how I am on the time. I know we started a little bit later. Francis, these are just different places that we want to make sure we have some time for discussion, but these are different groups that we actually adapted the intervention to. So, you know, for example, in Bogota, Colombia, we went there. We had a great partner there at the university in Bogota, and you know, she involved her students, and we did the training there, and they ran the project. They did a great job of it. So these are different places that we're adapting to.
Dr. Magaña, you have about 9 more minutes of presentations. You have until 11:15, and we're saving 10 to 15 minutes for Q&A. So okay. It's 10:51 now. Eastern.
Perfect. That's really perfect. Yeah.
Okay.
So I want to talk about another intervention that we're working on right now in Austin, Texas. We're still in that iteration process, really. And so I'll let you know how that's been working or not working for us. So, you know, we realized with Parents Taking Action that it would be really nice to have the psychoeducation, but kind of combine it with parent coaching. And I know we're going to have a great talk by Dr. Morier about naturalistic developmental behavioral intervention. And so that's something that has been, there's been more recent research about that, showing really good evidence that training parents how to use these different naturalistic strategies with their children, you know, shows good outcomes. But few, if any, have been tested with low resource or racial ethnic minority families. And so that was a challenge that we were running into. And so we developed a project called ASD Screening and Parent Engagement, Aspen. Sandra Venegas is really taking the lead on this. And what Aspen is doing is actually combining the psychoeducation from parents taking action with a, I always get confused about the initials, NDBI intervention called Project Impact, developed by Brooke Ingersoll in Michigan. And so we started combining those two approaches. And so this is just showing you what kinds of things we're including in there. We're giving out education, but also coaching around developmental strategies and behavioral strategies. But we also added challenging behaviors to that because that's something that parents ask about right away. So the families that we're targeting for this are low resource families, you know, because we want to address that gap in the literature, you know, that has not really worked with this population. So our recruitment is including children 18 months to 6 years old. So we want to get them as early as we can. But we know that oftentimes low resource families don't get diagnosed till 5 or 6. And, you know, address developmental, making sure that they have a developmental concern. So they don't have to have a diagnosis of autism for this intervention, but that is one thing that would include them, but also that they're showing they could be just at risk for developmental delays. And we're using MCHAT and SCQ to sort of screen depending on what age they are. And if they fill those screeners, then they're eligible for the study. And then how we're defining low resource, so they have to either one of these things, have Medicaid as their insurance provider, a parent has high school education or lower, and they're less than 200% of the federal poverty line, at or less than. So if they meet any of those criteria, they can be included in the project. And so we've gone through a lot of iterations. So we talked before about the iterations of developing or adapting an intervention. So we thought, well, we'll do this and we're going to do it in group because we want us to foster social support between parents. We've seen that's really important and helpful. And we tried it last summer. We tried it, you know, and this intervention is not just for Spanish speaking families. So we tried an English version of a group last summer. What we found in Austin, Texas, and this could vary by region, it's just so hard for people to get together in a group because people live all over the outskirts of Austin, especially with challenges finding housing within Austin. People are moving out of communities that they used to live in. And so people live north, south, east, west, you know, geographically pretty spread out. And so it was really hard for them transportation-wise to get to the group on a regular basis. It was also really hard to find a time and day that they could all meet. So we had to pick a day when some of them could meet to try it out. And then we thought, oh, it might work better in Spanish. So in the fall, we thought maybe the Spanish speaking families are more cohesive, so they're going to get together. And we found the same barriers. So again, transportation, finding a single time. And they have, a lot of the families we initially worked with did have a diagnosis. Their child had a diagnosis of autism. They were a young child. We have a great developmental pediatrician in Austin who's been really shooting at getting kids diagnosed early. And so they're seeing a lot of the Spanish speaking families and getting them diagnosed. But then they're right into therapies, right? And so it's hard to schedule around that. So we switched to the home visit model, you know, because we saw that it worked so well with parents taking action, overcoming all of the different barriers. And so I would say one challenge that we're going to face with the home visit model, I think it works really well, but we'll talk about COVID-19, of course, and how that interferes. But one of the challenges is if you want agencies and providers to adopt this intervention, they don't often want to do the home visit model for various reasons, legitimate reasons. It may not be as cost effective. They might be worried about liability and other kinds of things. So that's a challenge I find, but I find that the home visit model is just so great for low resource families. So we developed all of these materials. You know, we developed a new manual and different developmental, we're using developmental milestone checklists. We're actually using the CDC materials that are already in Spanish and English and different languages. And a lot of visual supports that we developed using video supplements to show examples of strategies. You know, it's important that parents choose the goals that are important. So we have that goal setting built in and checking in on people's goals throughout the different sessions. I believe it's a 12-week program that we ended up with. And so we train parents on all of these different aspects. So a key part of this, we just learning from parents taking action and the importance of peer leaders. We're using student clinicians to do the coaching piece. So we provide extensive training for the student clinicians. And they come from different disciplines. So special education, social work, speech and language, psychology, mostly graduate students. And we give them a 2-day training on that. And then the peer leaders, parents who have a child with, usually with a developmental disability or autism, we provide training for them too. And we have them involved in some of the sessions, but not all of the sessions. But then COVID-19 hit, right? So we did our training in January for this. We started recruiting families, started to assign families, and we started with Spanish-speaking families. We had 5 Spanish-speaking families we were immediately working with. And then mid-March, Austin started social distancing procedures, and we had to stop everything. So right now what we're working on is further adaptations for remote delivery. I know a lot of people probably are doing remote services, telehealth and things like that. So everybody's learning how to do that. I mean, some people already have experience with it, but our biggest challenge is that because we're working with low resource families, they don't necessarily have internet in their homes. In fact, out of these 5 families, we had our students call them to see what they have available. And I think maybe 1 out of the 5 had actual Wi-Fi in their home. They all have smartphones. Maybe one of the additional one had unlimited data, the rest don't. So that makes it a financial burden for them to receive the material remotely. So we're trying to figure out what to do about that. Also trying to get IRB approval for the change in how we're going about this. So it is a process, and we're in the middle of that process. It does take a lot of time and effort to develop materials for specific populations and for low resource populations, but we're determined to make that one work. But I do want you to think about, for discussion, how you might use some of these ideas to culturally tailor an intervention or a service or program or materials. You know, what you're already doing, and ideas that you have to share with the group, but I'm also open to take any questions.
Excellent. Is this the end of your presentation, Dr. Magaña? I want to make sure.
Yes.
Okay, perfect. So we do have some questions for you in the Q&A, but if any of you have any comments or questions with the discussion questions that are showing on the screen, please be sure to add them to the Q&A as well, or in the chat box. So I'm gonna go with the first question. Thank you so much for this information, Dr. Magaña. You're awesome. We have a few, we didn't get to do a Q&A for Dr. Gass, so there was just a couple comments or questions for Dr. Gass as well. So if you don't mind, when we get to that point, Dr. Gass might have to jump in to answer some questions.
Yeah.
Let's see. So this question is for you, Dr. Magaña. I really like the surface deep / deep approach to cultural adaptation. Do you consider back translation a surface approach, for example, to adapt items on a screener across language groups? And then there's a follow-up question. it seems like deep approaches are necessarily mixed methods in nature. Are there solely quantitative approaches that can effectively result in a deep cultural adaptation? And this is also in the Q&A. If you would like to pull it up, I don't know if you can with your PowerPoint up.
I don't think I can. What
Okay.
screen is showing, but yeah. So this sounds like a researcher asking.
It's definitely from a researcher.
Yeah, because forward back translation is a method used in research for translating instruments, translating measures and instruments to make sure that they are, you know, you're conveying the same content, and across different languages, you might be saying it a different way, but you want to make sure you're conveying the same. So the idea is you translate something from English to Spanish. You have one person do that. Then you have a different person translate from Spanish to English. And then you look at the discrepancies of the two English versions, make changes, and you maybe have a committee to come together. And so it is kind of an involved process. We generally use that process for the research measures, for sure. But for the content of the intervention and program, we've used different things. Like one approach I've used is 2 forward translation methods, and sometimes that you can catch different things than you would catch with the back translation method. So having one person translate from English to Spanish, the other person from English to Spanish, and look at Spanish versions. So we've used that, or an iterative process where we have somebody just translate everything, and then we have somebody else who's fluent and native in language is Spanish, making sure both of those people are, and that that person will check over. We have several people, usually we have several bilingual people on our team who will read and make edits and make changes. And I would say to this, there's never anything perfect like in the content. So to this day, we're catching things that we should have changed before in English or Spanish. And so it's never perfect. But so for the intervention itself, we're not using the back translation, but for the measures we typically have. But a lot of our measures were already translated in Spanish, so we don't want to reinvent the wheel. We go back and we find those measures that have already been translated using appropriate methods, and then just translate any new measures. And I forget the second part of the question now.
The second part was, it seems like deep approaches are necessarily mixed methods in nature. Are there solely quantitative approaches that can effectively result in a deep cultural adaptation?
So that's where I knew that it was a researcher, because when I was talking about deep versus surface, I was talking about the intervention itself, not about the research part of it.
Gotcha.
So the intervention itself, you wouldn't categorize as mixed or quantitative methods. I've always used mixed methods to evaluate interventions, but that doesn't relate to deep approach. So deep approach is more about what is the content delivery of the intervention. How are you taking into account culture on a deeper level? So are you using cultural values and other kinds of things?
Gotcha. Thank you so much for that answer. The next question is, how can, and this is for Dr. Magaña, how can I help a student's family that all members have deficits? I want to help serve this entire family.
Yeah, that's a really good point, because many families have more than one child who has a developmental disability, right? And so, so you want to be able to make sure that they have the right resources for that child. You know, and if you're helping them individually, I think it depends on if you're providing parent education or are you providing coaching. If you're providing parent education, it's good for you to know in advance, you know, who the family is and if they have other children with disabilities, so that you can take them into account as you're delivering the information. You know, this might apply for this child, but maybe this child who has a different challenge, you know, they may not benefit from that, but they may benefit from a different one. So yeah, it adds an extra layer, I think. But when we do the intervention as research, we generally have the parent working with one child, but we're hoping that the strategies that we're teaching will help them in working with the other child as well.
Excellent, thank you. She sent a follow-up message saying thank you. The parents also have some deficits. I think that's the issue as well.
Mm-hmm. Yeah. Yeah, and so so that's a different tailoring, right? That's a different approach to tailoring materials, because you want to make sure that your materials are at the right literacy level for that parent. And I think using more visuals and things like that can go a long way in providing education to those parents. You may need to take more time to explain concepts and break it down. And one of the things we did with Parents Taking Action is we did integrate taking more time around certain concepts, like the concept of play. We wanted to take a lot of time to really explain what, the importance of play, because a lot of families just weren't familiar with play as that child's job, as what the child should be doing, and they were more familiar with sending them off to play, right? Also, other things that they were very unfamiliar with, we took extra time to explain, like the idea of rewarding, wasn't something that many Latino families were using or thought was important to use. So really explaining the importance of, specifically with children with developmental disabilities, how rewarding can be important, or following your child's lead. Some families just like, why would I get on the ground with my child and follow them around when they're doing something weird? So extra time to explain concepts depending on the population you're targeting. And I think that could work with parents who also have intellectual disability or other challenges.
Thank you. Have you ever experienced an intervention that was just not appropriate for a particular family due to either their values, their dynamic, culture, so on and so forth?
I'm trying to think. I think, yeah, well, for Parents Taking Action, we found that parents who are already pretty educated about some of the concepts, so not all Latino families are low income, right? And so you might have families who are more middle class, more educated, and they've already educated themselves about the concepts. So some of the material was maybe not as appropriate. I think we might have had one or two families who dropped out because it just didn't meet their needs. So I don't know if that's, I'm sure there are other examples.
Thank you. Short and sweet. Thank you for that answer. Are there any intervention models that specifically focus on including fathers?
That is super, super important, right?
Yes,
fathers always get left out of the process. And our intervention can include fathers for sure. I mean, because it was a research study, we wanted to make sure that it was the primary caregiver who was receiving intervention, and that typically is the mothers. But here's another challenge. We did say you can invite anybody to these sessions. Like you can invite grandma or your sister or the dad to these sessions. However, they usually wanted to schedule them at times when the dad wasn't available, just because it was easier for the parents. So usually parents would schedule these sessions, between 9 and noon because their child was at school and they could focus on this, but the dad wasn't necessarily available. So I think that's another thing we have to figure out is how do we schedule it at a time when both dad and mom could come, but then taking into account the childcare needs of their whole family during that time. So it adds a number of layers of challenges, but I know dads really want to learn this material as well.
Yes, thank you. I'm going to skip to a Facebook question. Someone on Facebook Live asked, what do you foresee in adapting these methods of intervention in the age of COVID-19? Our organization applies many of the methods you presented, and we have already shifted to Zoom webinars to continue our outreach.
Yes. Yeah, we have to do it. I mean, just not do things. So we have to try things out. with Aspen, what we're going to be doing, given that we kind of surveyed the families we had about their access to internet, we're going to be purchasing hotspots or ways that they can access internet and give them a tablet that has internet access to work with. Now that's an additional expense, like organizations can't often do that, but that's what we're going to be doing. Hopefully we'll get started this summer in kind of switching over and providing that internet access. So I think one of the things that to look into is that your school district may be providing internet access if there are children in the home that are attending school. So maybe now is a good time for some families, if the school district is providing that for free, to be able to deliver it. But that's been a challenge for us, is trying to assess internet access for families. That's a big challenge. But then, you know, once they do have internet, I know there are groups and organizations and there are people in Austin that do this kind of coaching over Zoom. But I will say it's not ideal. You know, it's a little harder. And I've talked to the student clinicians that do that, and they say, yeah, it's a little challenging doing that. So that for the parent education, it works fine. I'm sure, as long as the person has internet access, but for coaching, it's a little more, you know, maybe some people have some ideas about that.
Gotcha. Thank you. Just a question about your promotoras, make sure I say that correctly. What other practices or thank you, approaches did you learn from the promotoras? You mentioned starting with a story. Were there others?
We learned so much from them. First of all, yes. So we first tested working with promotoras around a health intervention. And so they educated us about the story idea. The other thing is the time for the intervention. So we designed these sessions to last an hour because that seemed more realistic to do. But all the promotoras came back to us and said, no, we can't do this in an hour. It has to be 2 hours. And the families were willing to, the families also wanted to have that lengthier visit with the promotora because they did a lot of sharing. And that's the idea, right? Is to be able to share about your child and how it relates to the content that you're conveying. And so that took them extra time. We're finding that doesn't work in all communities because we're adapting this program in the African American community in Baltimore, and they do not want the extra time. So not to generalize to all African Americans, but at least in Baltimore, it was more of a challenge. They preferred to have a shorter time. So that doesn't, you have to adapt that to what families want. That was an important lesson. And then the other thing is, when we get to the advocacy, you know, they were delivering material, they were delivering some content about advocacy, but they were also sort of tailoring to the individual family what their advocacy needs were and trying to give them specific strategies. And so the promotoras gave the Spanish-speaking families some really good strategies that worked for them that I would never thought of, you know, because they're parents, right?
Right.
So I want to just give one quick example of that. One parent was trying to get ABA therapy in Wisconsin, and you had to contact the provider to get that there, you know, once you get on the waiting list and in the system, you have to get your own provider. And so this mom kept trying to call the provider. In Milwaukee, she never got a response. And so the parent told her, what you do is you go there and you wait outside the bathroom, you know, and because they have to go to the bathroom at some point, and then you talk to them. And that's what she did. And she said, Doctor, you know, I really appreciate you talking to me, and God will bless you for that. And I had to talk to her.
Yes, yes, awesome. So we are a little bit over our Q&A time. I want to just say thank you again for your time and your presentations. You did present for us yesterday as well. So thank you so much for joining us and sharing your knowledge and information. There's a few more questions in the Q&A for you. So if you don't mind just going through those, once you stop sharing your screen and during our break, you can go through and answer some of those questions by writing your response, if you don't mind.
Yeah, great.
Okay. I appreciate you. We appreciate you.
Thank
We are
you.
going to be on break until 11:30, and then we're going to have Michael Morier and Sharon Hines presentation at that time. So see you guys in 12 minutes.